so much. Good morning, everybody. I was going to say it's great to see you, but I don't know if anyone's familiar with the webinar platform on Zoom. I can't actually see any of your faces, so I look forward to some interaction at the end when we do get to go through some Q&A. So please do submit those if you have a burning question that I don't manage to cover through my presentation today. So I guess just to sort of set the scene, really, and who I am, who we are ARFID Awareness UK, and we are the UK's only registered charity dedicated solely to raising awareness and furthering information about ARFID. We are not for profit. We are a registered charity, and basically we exist just to provide individuals, be they parents, carers, people with ARFID themselves, but also medical professionals with up-to-date, relevant information, research, and support. I've put our social media icons there up in the corner. If you don't follow us on any of those platforms, we invite you to do so. Our social media presence is growing. It's still in its relative infancy, but we are even starting to appear on TikTok, which is our latest platform. I thought it was worth touching on our mission just to really also explain, why we exist, what we do. And that is very much that we exist. We recognize that there's a lot of uncertainty, hopefully why, many of you are on this webinar today. Some ambiguity and a lot of frustration that we ourselves, Stacey and myself, my other co-founder, experienced in not just getting a diagnosis and treatment, but also just, we want to provide that advice that might improve your journey, anyone else's journey, as they sort of start to explore ARFID and what it might mean for their family. But as I said before, equally, we do recognize, and one of the things we try to do is support medical professionals. We actually have a online CPD accredited training course that we do in partnership with the University of Winchester. And that was in response to this recognition that actually there's nobody out there training the NHS, if you like, training those people who are dealing with our children, our adolescents, our loved ones, in terms of educating them about what ARFID is, how to diagnose it, and how to treat that. So that is sort of the other half of what we do. So we try to equip medical professionals and parents, carers, individuals with the information that they need to really ensure people get the care that they deserve and that they need. And our vision, quite simply, is we want to make ARFID universally known and understood. So I think no retiring for us until we get there. So I guess just wanted to go through what this session is about and what I'm going to try and cover over the course of the next hour. I'm going to start with an introduction to ARFID, what it is, also what it isn't, what we know about how common ARFID is. It's one of the questions we get asked a lot, particularly by the press. The media want to know, how prevalent is it? And we're also going to touch upon a few observations that we've had as a charity. Then I'm going to look at the overview of the different ARFID subtypes. Some of you might not realize that not all ARFID is the same. So we're going to look at how they differ. Going to explore some of the early onset symptoms of ARFID as they present. Look at what a typical ARFID timeline is in terms of, what you might see over the course of its immersion. Going to touch on some interventions and introduce the importance of the multidisciplinary team. And then I thought what might be helpful is just to share some thoughts more as kind of a parent, carer of somebody with ARFID myself, the 10 things that my co-founder and I wish that, we'd known at the start of our journey, and that we've learned along the way. So I guess just to kick things off, what is ARFID? It is a relatively new term. Now, it was something that was introduced in 2013 when it first appeared in the DSM-5. And the DSM-5 stands for the Diagnostic and Statistical Manual. And that is sort of like the Bible, if you like, of clinical psychology. And it appeared for the first time in there. And that is when we sort of say the term ARFID was born. So although, yes, 2013 might feel like a long time ago for us, especially if you're living with ARFID, within sort of research and medical terms, it's considered, really in its infancy. Um, what defines ARFID is very much a pattern of eating that avoids certain foods or food groups altogether, or it's very much restricted in quantity. And by that, I mean eating, really small amounts. Um, that said, one of the most critical things is that this sort of avoidant or restrictive eating cannot be put down to a lack of availability, or cultural norms. Someone that's fasting, for example, for religious reasons, or choosing not to eat certain foods, that doesn't constitute ARFID. So it has to be that food is plentiful and that it's available. It differs compared to other restrictive eating disorders, mainly anorexia and bulimia, in that ARFID has nothing to do, it's not affected by a person's beliefs about the size and shape of their body. And to that point, somebody with ARFID doesn't restrict their food intake for the specific purpose of losing weight. In fact, quite the opposite. What we will find as somebody is older is it wouldn't be uncommon for them to say, I want to eat. It's just that I can't. My brain won't let me. So it's a really, really important distinction, particularly between ARFID and anorexia. How many people have it? This is the next most sort of frequent question we often get asked. Good question. We cannot say for certain. The best thing I can share with you is something that appeared quite recently in a medical journal, which was to say that the prevalence vary considerably, and it has to do with the methodology in which the study was undertaken. So what the setting is, what the population is. But what we do know is that ARFID seems to be just as common as some of the other well-known eating disorders, and those affect roughly anywhere from 0.3% of the population to 15.5% of children, and then much, much lower numbers for adults. And we'll kind of go on to talk about that a little bit later on. But ARFID does impact a wide range of individuals across ages and genders, and there are other medical and psychiatric comorbidities, which means sort of other conditions, particularly autism, that often can go along with that. So it's a bit of a frustrating topic of conversation that I can't give you an actual sort of number, but unfortunately, it comes down to research and how the research is done. And there's, as I've learned over the years, when it comes to scientific research and medical research, there's processes and limitations that just have to get followed that can skew the data. So I guess if we turn around and say, I think one of the safest numbers is if we look at prevalence studies that have been done in Canada, the US, France. It wouldn't be crazy to sort of think of it as anywhere between 1% to 3% of the population, which is really, really pretty high. What we do know, though, is that awareness is growing, and I've put in brackets there, thank goodness. Now, these are a few sort of screen grabs I took from articles that ran during this year's Eating Disorder Awareness Week, in which ARFID was the focus. Beat are the eating disorder charity that are behind Eating Disorders Awareness Week. They were the charity behind a lot of the press releases that went out. And I think it's important to say that yes, we have seen and they have seen a real increase in visitors to our website. They've seen an increase in people calling their helpline. It's not to say that ARFID as a condition is increasing, probably just that awareness is growing and more people are realizing that this is not, just picky eating. there is something a little bit more there. And I think that that can only be a good thing. If anyone sort of heard us talk before, I think getting ARFID out there, getting it spoken about, getting it normalized as a condition is a really important first step in getting much better access to diagnosis and care. So this is, I think, this is an important one to touch on, which is not everyone's ARFID is the same. When we talk about ARFID, it is, it's a very general term, and it has becoming that over the past sort of 5 years in particular, as research has started to increase, what we find is that more and more research is being done into what we call the four ARFID subtypes. And they are sort of broadly characterized as the sensory subtype, the lack of interest subtype, the fear subtype, and then combined, which, as the name suggests, is a little bit of combination of each. Now, if anyone is interested and you Google subtypes, there are papers that go into detail around sort of, the intricacies and some of the details of each of these subtypes. I'm going to spend just some time today talking about the two most common. So the two main presentations that have been observed in research are mainly the sensory slash lack of interest type. Those two aspects seem to go together. And then also the fear subtype. Now, the sensory lack of interest subtype is the most common combination, and this is the one that we see usually onset from early childhood. Lack of appetite is rarely seen alone. That's something that if it is the situation, it tends to be in the older age groups. So if you have a child that does show sort of a lack of interest, in my own case, it was the fact that even as a young child, I'm talking kind of 18 months, 2.5, 3, 4, I just wasn't getting, the badgering of mummy, I'm hungry. And it's something the nursery nurses, had even commented on is, she never says she's hungry the way sort of other children might. And that's what we mean, sort of the lack of interest, or sort of just, not kind of being excited at the prospect of meals or food. And that often goes along with sort of extreme sensory sensitivities. Now, these things are usually reported as starting in infancy, or from around the age of 2. Now, 2 is a really important number because this is when we tend to see the onset of the neophobic stage of food rejection. But this is something that can last a lifetime in terms of this sort of sensory lack of interest aspect. Now, in case the word neophobic is a new word for you, it absolutely was for me a few years ago. And I was going to say, points to anybody that can identify the photo or the book that this image has come from. The neophobic stage is an absolutely normal period of childhood development, and food neophobia itself is defined as the fear of trying new food, and it affects usually between 50 to 75% of children. It is why a very young child, I say very young, but experience it sort of sets on around age 2. It lasts till around 6 when a child starts to kind of grow out of it. It's the reason why they don't want to eat a biscuit if it's cracked. And the origins, I think, are fascinating, but they're really simple. It was a sort of biological, physiological way of keeping us safe. And if you think about the caveman days, and we've got our cave baby there, you didn't want a child wandering off into bushes and just eating any random berries. So this sort of natural anxiety or fear of new food was very much a protection mechanism that stopped us from basically poisoning ourselves. And that's why children develop this sort of this fussiness, or this sort of more become more particular about what they're given. And it's just, it's a very healthy, it's a very normal stage of development. What isn't normal is when that neophobic stage doesn't wear off. And that's what we see with ARFID when we talk about this sort of fear, this anxiety around food. So I guess going back then to the other main subtypes is, we've got that sensory, that lack of interest, that neophobic stage, which has stayed on. We then have the fear of aversive consequences. And by that we mean there's a fear of, vomiting, choking, and swallowing. This is something more research is actually ongoing in this area in particular. Because it is something that we tend to see later onset. So if somebody contacts the charity and says, I've got myself, or I've got a teenager that seems to be exhibiting these symptoms, it's something that we know has happened later as the child is older. It is less common of the two, but is still, one of the more prevalent ones. Often the result of a choking incident. Usually the family can kind of pinpoint a time and a place where, I like to sort of compare it to like a light switch. Something happened, a switch was flicked internally that's resulted in this fear. Um, it can also often be triggered by a point of transition, so a life transition, often between schools, or if there's a major life change within the family environment, the family dynamic, which just results in a generalized increase in anxiety. So, telltale signs that it's ARFID. How do you know? This is a funny one. I like to say when you know, you know. I think as a parent, um, there is that gut, and I will talk a little bit more about that gut reaction a bit later that says something isn't right. From a clinical perspective, a clinician would be looking at the range of foods that are being eaten. So typically it is less than 20. There is no particular number, but we're talking about, sort of a number of foods that you can count on two hands. Um, there also tend to be sensory reactive, and that means really specific to smell, to texture, to taste. Probably only eat one flavor of an accepted food. And I think, really critically, there is strong brand loyalty happening. Now, I myself work in advertising, and I know when my daughter was at nursery again, and starting to sort of show some of these signs and symptoms, and I already had that gist that something wasn't right. One of the things that the nursery nurses again picked up on, and was a bit of a joke, is, "Aha, mummy works in advertising," and this child is very brand conscious because, even at 18 months old, she would take a pouch and she would scrutinize the packaging, and she would only eat Ella's Kitchen, and if it wasn't Ella's Kitchen, she absolutely refused it. So we know that appearance and brands are very, very important, even to very, very young children, because packaging predicts the safety, it's the predictability. So one of the things I always say to people is, for example, if I give you an apple, it could be red, it could be green, it could be crunchy, it could be mushy, it could be tart, it could be sweet. You don't know until you take that bite exactly what it's going to be like. And for somebody with extreme food anxiety, that is too much to handle. Whereas if I give you a bag of Walker's crisps, regardless of the flavor, you know exactly what that food is going to taste like, and it is going to be the same every single time. So that is why we tend to see a lot of processed foods featuring heavily in the diets of children with ARFID, and why they tend to be kind of beige carbohydrates, because just by their very nature, they are processed, they are therefore predictable. And they also don't have very strong sensory properties. So things like bread, things like crackers, for that reason. Then it's important to look at the behavior of the child. If the child is showing extreme anxiety, if offered new foods or foods they don't like, that is a good indication that there's something going on. By that we mean, they may gag, they may vomit. We're talking an absolute extreme disgust response. So again, I look back at videos that I had taken of my daughter when she was weaning, and it was, you could see her, she would put her hands onto food and absolutely shudder, even just at the feel of it. Try things and really be gagging, be retching. She can walk into the kitchen if we are frying a steak in particular, for example, and there is an unavoidable physical reaction there where she starts retching, and that is not a child just expressing a dislike. That is a physiological disgust response. So what usually goes with that is extreme anxiety at meal times, avoidance of others eating. So again, not being able to be in the same room as other family members, um, not being able to handle the smell. There's usually, again, along with that sensory sensitivity, people with ARFID usually have really are super tasters. So my daughter, for example, we go for a walk in the woods, she'll smell wild garlic, you know, way before any of us can, or we can but before we can even see it, because her sense of smell is so good. So again, that goes with, if somebody in the room is eating pizza, it wouldn't be unusual that somebody with ARFID, for example, might not even be able to be in the same room as that individual. So to that point, they cannot sit with others to eat, and they might need distraction at meal times, which again goes against sort of all the typical instruction I think most of us parents are given when they're young, which is, remove screens with ARFID, and we can go on to talk about that a little bit later. You kind of get to throw the rule book out the window, and actually screens are great, because if it means, it's reducing that anxiety, distracting the child or the adult, the adolescent, from being wholly focused on what they're eating so that they can get enough calories in, then that's a win. Oh, sorry. Um, so I guess then looking at, who can help, who are the team that deal with ARFID, and what do they all do? There is always conversation amongst healthcare professionals around who can actually diagnose ARFID, and the answer is only a clinical psychologist can actually do the diagnosis. A dietitian, uh, will give a pretty good, should be very competent at being able to spot and review ARFID, but technically it's the psychologist that needs to give that diagnosis. That said, there are a whole group of medical professionals that are important and critical in terms of supporting a family, and supporting the individual. So for younger children, as I said before, the big priority is to prioritize growth, and that means getting enough calories in. So that involves and should be the concern of all medical and health professionals that you're engaging with. One of the other things you need to be looking at is managing appetite. So again, little things that can help, looking at short, frequent meals at snacks, and your dietitian is going to be your main point person on that in terms of monitoring um, uh, the volume of food, but then also, as per the next point, that dietary balance. So looking at supplements, is the individual getting enough vitamins and minerals that they need, and are there supplements that can be given that will help in that area. Then the other angle is the sensory issues, which, as we discussed, are usually going to be prevalent there. And this is where an occupational therapist or a play therapist can really help in terms of working with an individual to sort of remove some of those sensory barriers, helping them kind of function in the day to day. An occupational therapist's job is is to really help people navigate the world, help them function to their best degree possible. So this is where occupational therapy and play therapy can really help. And then related to that, there is a bit of overlap that links to this idea of managing anxiety and psychosocial distress that comes with, having ARFID, that affects both, both parent and child or adolescent. And that's where the clinical psychologist, the counselor, educational provider, be that a teacher, really have a very, very good role, an important role to play. So, I think you can see, especially for younger children, when we talk about the value and the importance of the multidisciplinary team, this is what we mean. And I guess as a parent, if you're looking for support, these are sort of all the point people that you want to have on your side. For older children, for adolescents and adults, it's very much, it's going to be very similar. All of the strategies that exist for young people are also applicable to older individuals, and that is something we get asked quite frequently. Was, I'm an adult myself. I could be in my 60s, even older. This is something I've lived with all my life. What can I do? And the answer is it's very much the same, as what you would do for somebody younger. Obviously, with some adaptations, but the same team applies. What you would then look to do is add in cognitive behavioral therapy, probably to help deal with manage some of that anxiety, that stress, relaxation therapy, taste trials, and that's where a psychologist or CBT therapist might be able to help. Um, so I guess with that in mind, looking at the timeline in terms of, what do you look out for as a parent, or some of you might be medical professionals yourselves, and what does this sort of development, or emergence of ARFID look like? So what we've got here is, sort of some of the key, I guess, stages. We've got that first year where baby is starting to develop food preferences. What you might see are some signs of sensory sensitivity. I guess for myself, I remember Googling a lot and learning about something called the high needs baby, and thinking right away, this is my child. She is definitely a lot more sensitive to what's going on in the world around her, much more stimulus than what I was seeing from other babies of my friends. They might have had some aversive experiences when it comes to food, and again, you might start to see a lack of interest in eating. If somebody's breastfeeding or even bottle feeding, again in that first year, there might be sort of signs that there is a sort of general lack. There might be issues in feeding in that early stage, and there might be some sort of medical complications. While we can't say for sure, we don't know why some children go on to develop ARFID and others don't. What research has shown is that those that go on to develop ARFID um, tend to have had gastrointestinal issues when they were younger. So that could have been acid reflux. That could have been some medical complications with their bowel or their small intestine and their stomach. They might have been premature and been nasal gastric fed as infants. So, these are all things that are early indications that ARFID, might then sort of rear its head. As we get on then into the second year, that's when the neophobic stage, as we discussed, starts to kick in. This is when a child starts to develop food preferences, and we start to again see these increased signs of sensory sensitivity, not just to taste, but it could be to sound, to light, to smell. Again, you might have had some aversive experiences and this lack of interest in eating. From 3 years is probably when, as a parent, you're starting to think, something isn't right. My child doesn't appear to be progressing. Often it's beyond sort of purees, crunchy carbohydrates the way, other children are. They're starting to develop more complex tastes. They're starting to engage with food a bit more, be that a wrap as a sandwich or spaghetti bolognese. They're just sort of not moving on. And that's when we really start to see sort of disgust and fear come out. Now, something that I used to say, and I found myself saying repeatedly to medical professionals when I was at the start of my journey, which is, if I didn't know any better, I'd think she was scared of food, which seems ridiculous, or seemed ridiculous at the time, because ARFID as a diagnosis was barely known. So, but that was my interpretation. My mother's instinct was to say, I would say she's scared of food, just the way she physically reacts. Now, 3 is when a diagnosis of ARFID is considered possible, in that at that point, it is it is possible to say this is not just regular developmental neophobic stage behavior, there's something more going on. And you might start to need special arrangements at nursery, at school, if once the child enters reception, and some management of sensory issues and anxiety in general that often accompany the ARFID. Now, eight becomes a sort of a bit more of a pivotal time, and I remember the shock and, I guess, if you like, slight horror when we were going through the ARFID diagnosis process, and I was told, actually there is very little that could be done to help me and my daughter until the age of 8. Now, she was 3 at the time. We'd experienced problems since the week she was born with feeding, and to be told at 3 you've got to wait another 5 years was absolutely devastating. Now, there is stuff that can be done, but 8 is sort of the age at which a child's cognition really starts to develop. They're able to start to think about their own eating in a way that just developmentally they aren't able to until then. So that is when we say they might be motivated to change. They might want to try things. They might start to express more of an interest. One of the challenges of ARFID is that people, especially children, are often very happy with their diet. And it's only those of us who don't have it that feel a sense of frustration and disappointment that, their diet is as limited as it is. But usually, they're very happy with their handful of foods, and they're not feeling any need to change. But 8 is when, they start to become sort of a bit more socially engaged. They might want to start sort of fitting with their friends. Their curiosity, their confidence might start to develop. So this is the point at which a clinical psychologist would say, okay, if that is the case, then something like CBT or anxiety management therapy might be appropriate, might be successful, in that it will start to have an effect. So I guess what happens after 8? What is the prognosis? What does ARFID look like when we get into adolescence and beyond? And what we see is that as somebody enters those teenage years, that again, that motivation to try new foods may increase as that young adult wants to fit in socially. So again, it's about, they want to go to sleepovers, they want to go out to the cinema with their friends. And then that increases up to adulthood. So again, when they start to transition into secondary school or go to university, one of our trustees often talks about one of her patients who, was getting ready to go off to university and really wanted to be able to have a beer. They wanted to be able to go to the student union with their friends and have a beer. So that was something that she was able to work with him on. So these are the types of things that end up being kind of catalyst, if you like, to start seeing some change. That said, for a lot of people, ARFID is, or for some people, ARFID is something that they will be able to slide out of, particularly if they are neurotypical. And as they develop and as they get sort of, I guess, some of these these sort of social motivations, then, cognitively they are able to overcome their fears, overcome their anxieties, and really work to expand their repertoire. For others, however, ARFID is going to be something that, it sort of bounces back into their lives at different periods. And what we see is that this sort of anxiety and depression can be a trigger for sort of increased anxiety around food. So we start to see some of those early food avoidances may reappear. And what you might get is this sort of fluctuating pattern that is triggered by, stress, triggered by big events. Um, One of the things that's really important to note with ARFID is that in order to deal with it most effectively, in order to, I guess, kind of battle it, overcome it, the individual has to want to change. And you know, this is why we sort of say from 8 years onwards, um, that's when you're most likely to see kind of inroads made, is because the change has to come from within, and no amount of pressure or stress will do the job. In fact, as we'll go on to discuss, will actually have a negative effect. So I guess at this point, I thought, having touched on the basics, it was worth covering these 10 things that, I wish I'd known. Um, and things that I've learned over the years as a consequence of being a parent to a daughter with ARFID, as a consequence of having, been on this journey and co-founded ARFID Awareness UK. And the reason why Stacey and I decided to found the charity is simply because we were both going through the process of a diagnosis for our children at the same time. And what was absolutely crazy to us both is when we put ARFID into Google, practically nothing came up. And um, it struck me as completely, well, unbelievable at the time, to be honest, that, if someone is given a cancer diagnosis, for example, the first thing they will go and do is probably look up Macmillan Cancer Support, or Cancer Research UK. They will search for information. And back in 2019, despite the fact that ARFID first appeared in the DSM-5 in 2013, there was barely anything written about it. And so we both felt that there was this real need. There was a need to have some place where people could go for trusted, evidence-based information and guidance. And that's how ARFID Awareness was born. So these 10 things are things that we've kind of learned over the years, and looking back, I just think, gosh, I wish I'd known at the start. It might have made my life easier. So hopefully it does that for some of you as well. So I guess the first is probably the most brutal, and that is that there is no evidence-based cure. Um, but it's not doom and gloom, right? There are treatments that can help, and research is ongoing. And I think one of the things that struck me and found really, really frustrating when I was talking to GPs and getting referrals to pediatricians, and found myself, at the Evelina Children's Hospital in front of their behavioral feeding team at the time, was the first thing people would say to me is, well, what do you want to get out of this? And I used to look at them like they were absolute morons, and just, be really confused and think, well, how is this not obvious? I've got a child that doesn't eat table food. She is wholly dependent on super smooth purees and baby snacks, basically. She's 3 years old, and she's not engaging, she's not progressing. How can you not see that there's a problem? And I guess what I appreciate now, but what no one ever said to me, is that, ARFID is a medical condition. It's a psychological condition, and it's something that you have for life, in the same way that, someone might develop anxiety, they might develop depression, they might have be autistic or have other chronic conditions. And this is part of who my daughter is. This is what, shapes her. And with her, it's, and with anyone with ARFID, it's about learning to manage it. And for some people that doesn't mean overcoming it, but there is no recipe or no formula to actually flick a switch or, snap fingers and say, okay, this is, this is the treatment pathway, and, you will be cured. Everybody's ARFID is different. Everybody is unique. Everybody has their own set of challenges. And because this is such a new diagnosis, and the way medical treatment works is that, research has to be done and it has to be proven, and that takes time. And we are, we are just sort of at the cusp of starting to develop. More and more research is being done. There's more and more interest, more and more awareness into how can we treat ARFID? How can we help people overcome this? And so, progress is being made, but, we are dealing to a degree with a little bit of the unknown. That said, we're all in it together, and there are silver linings. But I think it's really important to be clear with people that, there is no magic bullet answer. The next one is that there is a relationship with autism. That's something we often get asked, but not always. And I like this sort of Venn diagram here, which, by the way, is not done to scale, which is to say, some people might be neurotypical and not have ARFID. Well, majority of people are who are neurotypical, they don't have ARFID, but there are some that do. And just like there are some people who are autistic and have ARFID, but some people have ARFID and are not autistic. So, there is an overlap. Autistic eating is different to ARFID, and it can be difficult to separate the two. And often we hear from parents who are frustrated because a medical professional is saying to them, no, this is autistic eating, this isn't ARFID. But absolutely, you can be autistic and have ARFID. You can be neurotypical and have ARFID, and you can be neurotypical and neurodiverse and not. So it absolutely does not discriminate. And I guess this links back to what I was saying at the very start with point number one, is that in some people, they do manage to slide out of it. More likely if they are neurotypical, and there is that desire, and they will sort of overcome it, and ARFID will disappear over time, which is great. On the other hand, it might be for life, and that's okay too. There is, like I said, there is no hard and fast rule when it comes to ARFID, and I think accepting that as a parent has been one of the hardest, but also one of the most liberating things that I've personally had to do. Gosh, in the 5 years, 8 years that I've been on this journey myself. The other is that something we often get asked is, do I need a diagnosis? Is it necessary? And the answer is no. A diagnosis isn't necessary, but it can help. And it can help in terms of you, the parent, advocating for that child, that adolescent in your care. As an adult, it can sort of help validate what you feel all along, and sort of give you the confidence and even sort of the credibility with others to say, no, look, this is a medical condition. This is not just picky eating. It's not in my head. But no, there are a lot of people that choose not to go down that route. And to be totally honest, for probably the majority of people, getting a diagnosis is difficult, if not impossible. But so it's not necessary. But if you choose to go down that route, that's absolutely fine. And yes, you might find it helpful. Number 5, to that point, what I was just saying around, despite your best efforts, you might not be able to get a diagnosis, is that the help that is available is limited, if you haven't discovered that already. And it is a postcode lottery. And this is very much something, as a charity, we are fighting to change. Something we are always trying to draw awareness to is that at the moment, there are no nice guidelines. And part of that is because if there are nice guidelines, then there has to be diagnostic and treatment pathways in place. And it's very difficult to do that when there is no evidence-based, proven treatment to provide. So it is a bit of a mess. It is a bit of a slippery slope. A lot of people do choose to go private. Um, our counsel is always, if you do choose to go down that route, we as a charity can never recommend any particular providers for obvious reasons. However, what we do say is check that whoever you are seeing is registered with their accredited professional body. There are a lot of individuals out there that are profiteering from this new kind of emergent diagnosis. They see desperate parents who will do anything to try and help their child. Um, and they are offering cures. And what we always say to people is, if a cure was that simple, the NHS would have adopted it years ago. So if it sounds too good to be true, it probably is. Always check that whoever you're dealing with is experienced, is trained in ARFID, and like I said, that they are registered and accredited with their governing body. Number 6 is that you have a right to challenge medical professionals, and I've put in brackets, they are not gods. And this was a big learning curve for me, at the start. I saw 3 different GPs before I was able to sort of had the confidence to demand a referral to a pediatrician, and that went hand in hand with the research that I was doing myself, and the hunch that I had that something just wasn't right with my child, and she wasn't progressing normally, that it was more than picky eating. And I had 3 different GPs say to me, we all know that child that survived on white bread and chocolate till they were 18 and they turned into, a strapping young lad who's perfectly fine. Well, I now look back on it and think that that child probably had ARFID. But, I did have the fourth one say to me, the thing is, Nicole, the more people you ask, the more answers you're going to get. And, you know, looking back on it, it was a really sort of frustrating time, but it made me grow a thicker skin. And what I've learned is that, doctors, medical professions don't know everything. They are not gods. And I've come across many in my time who are not familiar with ARFID. And bless them, I would say the majority have been wonderful, open, collaborative, and helpful individuals who have been keen to share information and to learn. But, we always say, if you feel that you're not being taken seriously, if you feel that somebody is just not listening and being dismissive of your concerns, go see another opinion. That is your right. Trust your instinct, because you have that right to challenge somebody's point of view just because they have a medical degree or title in front of their name. Number 7, this is probably the most important thing that was ever said to me, and I repeat it on a regular basis, and that is that all food is good food. And this came from a dietitian we saw at our local hospital, who asked me. We saw her 2 days before Halloween, and she said to me, "Is your daughter going to go out trick or treating?" And I said, "Yeah, probably." And my daughter was 3 at the time, and said, "Okay." Um, when she gets home, if she wants to eat all her sweets, let her. All food is good food. And it sort of took me a little bit by surprise. I mean, I hadn't even kind of considered it. I guess most parents go into Halloween thinking, you're going to portion out your child's sweets, and you don't want them eating that whole bag in one go. Um, but the line "all food is good food" really gave me permission to change how I parent, change how I think about food. And friends often joke that I'm great to hang out with because I see the value in everything. A bar of chocolate is a great source of soluble iron. Cake has eggs and milk in it, which is great. Same with pancakes. With Nutella, slather it on because those nuts are a source of protein. So there is value in all food. Nothing is ever at least in our house is considered bad, and we spend a lot of time educating, whether it's teachers, dinner ladies, that really, friends and family members, all food is good food. Number 8, seasonal holidays would be hard, but it does get easier. And this was taken, I think, when my daughter was around 4, um, there was absolutely no way she could touch the inside of a pumpkin, but she was really, really keen to carve one. But of course, the smell of a pumpkin once you cut into it is just too much for her. And she was literally retching. She was gagging in the kitchen. So we got out a clothes peg so that she could have a go at carving a pumpkin. But I think, things like this that I never anticipated when I had sort of, I'm Canadian growing up, Halloween's a big deal. This vision of carving a pumpkin and her not being able to do it, not wanting to go to the pumpkin patch because, the mud is sticky and slimy, and not wanting to get her hands dirty and all that kind of stuff. It was upsetting. Christmas dinners. I think I'm only now at the point, and she's 8, in the last sort of year where I don't care if she has shreddies for Christmas dinner. Again, my vision growing up, and I think as a parent, um, holidays, Christmas meals, really important. You have this vision of everybody sitting down together as a family, and I projected my own feelings and my own disappointment onto the fact that all she wanted was toast. I'm now at the stage where I kind of go, that's okay. It doesn't matter. Like, Christmas dinner is about eating what makes you happy, and if she can just sit at the table with us and have a bowl of cereal, great. But that's been a big journey of acceptance for myself, and it was something that I've had to work on, and has taken time. Number 9 is that ARFID, if it hasn't already, will put stress on your relationships, and it never really goes away. My mother, bless her, as well-meaning and supportive as she is, she will still every once in a while say to me, "But have you tried this?" Or my husband will, in a moment of frustration, just sort of say, at some point, you have to try new things, and it's like, no, that's absolutely the wrong thing to say. So, it's a fact. It will put stress, but again, it's all worth it. It's all manageable, and just learning to navigate it is part of learning to live with it. And number 10 was, it was and it's not our fault. And, I think this again is something that really sort of struck me and was a big relief to me when I had a pediatrician just say to me, give yourself a pat on the back, in giving her pouches and letting her eat in front of the TV and trusting your instinct. You've managed to keep her off a feeding tube at this point. um, I nearly burst into tears in his office, and I hadn't realized the baggage and the pressure that I was carrying. And I think particularly, as mothers, we feel our job is to sustain. I mean, that's that to sustain this life, to grow this life. And if we cannot feed our child and feed our child in the way that we're anticipating, we feel that it's a failure. And so to have somebody else say to me, just as I say to you, it's not your fault. It's not because you did baby-led weaning. It's not because you chose to formula feed. It's not because, X, Y, and Z. ARFID is something we know is that a person is genetically predisposed to. It has links to anxiety-based disorders. And, for some children, as I said before, a flick is triggered, or a switch is triggered, something flicks, and they go on to develop ARFID. It's why you can have one sibling with ARFID and the other two that eat everything. It is not the fault of the parents. It's not the fault of anything that's done. It's just biology. So please, whatever you do, don't beat yourself up, because it's there's nothing you could have done to prevent it. So I think that brings us to the end. I'd said to Camilla that I thought I was going to leave plenty of time for questions, so apologies in advance, that I talked for longer than anticipated. But I think just before we go on to those, I just wanted to say that, and it links back to what I was saying at the start about what we've done to develop as a charity and why we exist. Is if you haven't visited our website already, please go on and find the resources tab, because what we have done is create a bunch of different resources both for parents and carers, but also things that you can print out and give to your healthcare professional to help facilitate conversations, make your lives a little bit easier. And those things are all free to download and use as needed. So that's me. I'm done. Thank you. I think, as I was saying, I think we are now going to open up the floor to some questions.
Yeah, thank you, Nicole. Yeah, and we have gone over a little bit, but there's so much information, isn't there, to pack in. So we'll get cracking on with the questions because we have had quite a few through. So we'll try and go through as many as possible. So the first one. My daughter is 4 and I'm certain she has ARFID. However, I've been told she cannot have ARFID as she's not underweight. However, she ticks all the boxes for all the symptoms of ARFID except the weight loss. Have you got any advice?
Yeah, this is a great question, and it's actually a really, really important one, one that we get asked quite a bit. Now, the diagnostic criteria for ARFID have actually recently been updated, and one of the important distinguishing characteristics of that is that a child does no longer have to be underweight to be given the ARFID diagnosis. In fact, you can be underweight, you can be normal weight, you can be overweight. And it all comes down to that lack of interest in eating. So to what degree that child is experiencing it, but also what those safe foods are. So if a child has a list of safe foods that include pizza, crisps, and white bread, and they have a reasonable amount of appetite, or we don't see an extreme lack of it, then given the caloric density of those foods, it is very possible for a child to be overweight and have ARFID. So absolutely, I would say that's where, again, you can go to our website, print off some of the resources that explain that, and then go back to your GP or your pediatrician and have that informed conversation by gently correcting them that they are misinformed. And you can tell them ARFID Awareness UK said so.
Thank you. Next question. How do we access treatment? We have a diagnosis from GOSH, but were discharged immediately after. Our dietitian has left our local hospital, so we have been dropped from the service. CAMS didn't want to know as he wasn't in the mental health crisis. Sensory fear subtype.
Yeah. And again, this is one of the sad and brutal realities of ARFID. And please bear with me when I say that unfortunately there probably is very little help out there. And this is where some people do choose to go the private route. So I'm in the exact same situation. We had a diagnosis from Evelina. We were discharged because my daughter's weight was normal. And so we were seen to be managing okay. There are no ARFID services in Kent where I live. And in fact, there are no child psychology services. So I am in, just like you, a black hole. What I guess if going private is not an option for you, the best thing you could probably do is ask to see you should have access to some sort of dietetic services in your area, which would be helpful just for nutritional monitoring. The other reality is, I think, there is very little that anybody is going to be able to do that you can't do yourself. And again, it goes back to the fact that there is no evidence-based sort of treatment formula. So depending on how old the child is, if they are 8 or above and they're really eager and they're wanting to change, you can look into getting some sort of CBT anti-anxiety sessions for them. You can also go online yourself and look at things that you can do from a sensory point of view to help with that desensitization. And those can be really simple things. So we have a sensory toolkit available in the resources section of our website. Now, it should be caveated that that was created for people with sensory sensitivities, not necessarily ARFID specific. We are partnering with De Montfort University to produce one that is created with ARFID in mind. However, some of the principles will still apply. So things like, taking your child shopping and just getting them to help put things in a basket. It's getting them to touch fruits and vegetables, or getting to touch packaging, anything that you can do, going down to the beach and step by step, how close can you get to the ocean, is all really, really helpful, because what we do know is anything you can do to remove those sensory sensitivities, lower that barrier, will only be helpful as that child gets older, in terms of helping them be able to try new foods when they feel ready to move on.
Okay, brilliant. Next question. Are there any suggestions around dental health? Keeping teeth clean can be quite stressful. Is there anything other than changing the toothpaste?
Oh, that's a good one. I haven't been asked that one. Do you know what? Even just brushing with water. Again, I think for a lot of people with ARFID or a lot of children, I know, just even getting the toothbrush on there. So obviously, for a lot of people, the mint is too much. Finding a fruit flavored toothpaste, using a fruit flavored toothpaste if possible. If not, just working on water. Water and a toothbrush is the best thing. And again, that's where some of that sensory desensitization comes in. So, start with just rinsing with water, then try brushing with a wet toothbrush. Once a child is really, really comfortable with that, you might be able to move on with the absolute tiniest, tiniest, tiniest amount of, let's say, a fruit flavored toothpaste. Often those are a bit more palatable than mint. And then just gradually again increase that amount. Fortunately, if a child develops a cavity in a milk tooth, that's gonna fall out. So by then, hopefully by the time, their adult teeth are coming in, they're a bit more capable of sort of brushing, and because again, you're able to rationalize it a bit more. I would just say start small, and something is better than nothing.
Brilliant, thank you. A few people I've spoken to believe a bout of neurovirus type stomach bug kick-started their selective eating ARFID journey. Does this also form part of the GI issues you mentioned?
No, at the moment, as far as I'm aware, there's absolutely no research to say that there is any sort of virological link to ARFID. So, I mean, again, I suppose you could probably say that well, so let me go back and say, we know that there can be an event or an aversive consequence that could trigger um, some aversion. So it would not be unreasonable to say, a really bad case of hand, foot, and mouth, for example, in the same way that a choking incident could be a trigger. But I think what's important to understand is there is a genetic predisposition before that in place that would have been there before, that triggering event. But again, like I said, as far as I'm aware, there is no research to say that ARFID could be brought on by any sort of gastrointestinal bug or any sort of virus that then sort of leaves ARFID as a legacy.
Okay, thank you. Have you got time for a couple more?
Sure do. Yeah, go for it.
Okay, yeah. So my son is 10. At home, he displays all the signs of ARFID, but at school, he sits and eats with his peers in the dining hall. He does have an autism diagnosis and masks in other areas of school. Is it possible he's doing this with ARFID too?
So this is an interesting one actually, because I experienced a situation myself. Now I need to caveat the fact that I'm not a medical professional, so I'm not able to I guess give a diagnosis to any case in particular. What I can say and what I can share is what I've learned and was taught to me, which is that as parents, and particularly mothers, not to say that this can't be with fathers as well, but mothers tend to be the primary caregiver. You are the safe space. So we tend to see ARFID at its worst when the child is with us as mothers, and that's because it goes back to sort of a contamination fear. So the example I had, when I spoke to Dr. Gillian Harris about it, was to say, I'm really confused because my daughter will eat McDonald's chips in a McDonald's restaurant. She will sometimes eat them in the car, but she won't eat them at home. Why is that? And what Dr. Harris explained to me is that I am her safe space. And what, depending on her level of anxiety, she doesn't want to contaminate that her safest of space with that fear. So outside the home, we often see children more likely to try new foods. So again, holidays are actually a big one. Holidays can be something that, you know, we fear because, oh my God, how are we going to get access to the safe foods? However, I think those of us without ARFID can sort of testify to the fact that we're more likely to just try a new food on holiday because we're relaxed. You know, you're out of your environment, you've got the sunshine, you've got the fresh air, all the rest of it. And the same holds true for ARFID. So I myself have observed that my daughter was more likely, in fact, she first tried McDonald's chips on a trip home to Canada because again, she was distracted, she was out of her normal routine. So I would say yes, it would not be unusual for somebody with ARFID to eat certain foods outside of the house, in a school environment, at a friend's house. But then the closer you get to home and closer you get to that safe space, the least likely that food, or the less chance that food will be accepted, even if they devour it, you know, like I said, at school or at a friend's house.
Okay, thank you. We'll just fit in a couple more questions because I know we've gone over a little bit, but next one. So is it a good idea to continue giving my 8-year-old new food choices regularly, or will this increase his anxiety? Shall we just stick to the 5 existing food choices?
I would. There's no evidence. So there was a lot of chat about where they're thinking around a learning plate a few years ago. In fact, after being at the Evelina when we were started the journey, there was, you know, we were told use a learning plate. So the idea behind that was always present the safe foods and then, you know, put something new on that plate. Again, speaking to Gillian Harris, who actually was the author of the paper that led to this idea of the learning plate. Gillian says they've since found that it just doesn't work. And anything that kind of adds to pressure, so even just offering it feels like a burden. If somebody is saying to you, you know, Susie, Nicole, do you want some of this? It's like, no, no, thank you. No, thank you. Especially when the child's at an age where they can advocate for themselves. So my advice to you, and everything that I've learned and I've been told is back off completely. And what you'll find is, when your child is ready, and it will probably surprise you and very much be out of the blue, is when he'll say, "Can I try that? Can I have a piece of that?" And then just go with it. Don't make a big deal about it. Don't go over the top. Don't reward it. Just as hard as it is, and as much as you're jumping up and down inside, just be cool.
Brilliant. And last question. My autistic teenage son has all the symptoms of ARFID and is losing weight. We're told he's not eating enough protein and he needs supplements. What would help, as taking supplements is like a new food, but worried about his health?
Yeah, this is, I mean, medication and supplements are a really, really tricky one. And this is where it's really important, to find a dietitian that you can work with to find, something that your child will be able to handle. I can really appreciate, the protein conversation because that's something that myself I have to work with. What I've personally been able to find luck with is, chocolate, you know, protein chocolate milks. My daughter doesn't mind them, so that's been a way that we've been able to get protein into her diet. And so, you know, there are some dietary supplements out there that are designed, you know, things like juices, ice creams. I guess the best case or the best hope would be that there is one out there that your child, will accept. But this is where it's really, really important to speak to a dietitian about, you know, what options are available and out there. And it's just trying everything and seeing if anything sticks.
Brilliant. Thanks so much, Nicole. And that brings us to the end of today's webinar. Apologies, we haven't been able to ask everyone's questions, and we have had so many in, as you can imagine. But you can find out a lot of information on your website, can't you, Nicole? So if you go to
Absolutely.
arfidawareness.co.uk, and